So we will talk about degenerative disc disease on imaging. Disc lesions are generally classified into different subtypes. So disc can be called normal, but we need to exclude aging changes. Disc lesions can be due to congenital or developmental variant. There may be degenerative or traumatic lesions, and among the degenerative or traumatic lesions there may be annular tear, maybe herniation, maybe degenerative, solely degenerative. So among herniation, disc may be protruded, may be excluded, or intervertebral herniation that will be discussed later on. In degenerative case, there are also two types: spondylosis deformans and intervertebral osteochondrosis that will be discussed later on. Disc lesions also can occur due to inflammation or infection, or due to neoplasia, or due to morphological. Disc lesion may be also a morphological variant of unknown significance. So the changes that occurs with the pace of age in the intervertebral disc are normally, we know that as we age our intervertebral disc becomes more dehydrated, but we have to keep in mind that normal aging disc should not be reduced in height, the height should be preserved in normal aging disc. Also, disc margins should be regular in normal aging, and in normal aging radial annular tears are unusual consequence. So aging may be normal or pathological. Normal aging, also known as spondylosis deformans, it involves the annulus fibrosus and adjacent ring apophysis. So adjust the ring apophysis and its adjacent annulus fibrosus is involved in normal aging, but in abnormal aging the central part of the disc, that is the nucleus pulposus and vertebral end plate, is involved. So these involvement results in case of normal aging. We see anterior and lateral marginal osteophytes, the osteophytes that are seen in anterior and lateral margin, it is found in normal aging. Also in normal aging we find small amounts of gash near the epiphyseal anthesis. In case of pathological aging, we see end plate changes and reactive bone marrow. Also we see large amount of gash in the central disc space that can be seen on X-ray or CT scan. So degeneration of disc includes the end plate of the vertebral body. So we may find in the end plate of a vertebral body, we may find sclerosed end plate, we may find defect in the end plate, we may see modic changes in the end plate, or we may see osteophytes in the end plate. And in the disc we may see fibrosis, annular tear, desiccation, loss of height, and we may also see mucinous degeneration of the annulus. So these are the degeneration change. So in terms of reliability, the early degenerative findings, that is the loss of height, is not reliable, it is less reliable, but the late degenerative changes, which are sclerosis of vertebral end plate, osteophytes, vacuum phenomenon, classifications are more reliable. Here vacuum phenomenon it occurs as the disc is the boundary of the disc is breaked. If the boundary of the disc is break, such as, and this break weak side or this hole in the vertebral disc will cause air to come in the vertebral disc, and we will see air in the central part of the disc. So this is known as vacuum phenomenon that is found in the late degenerative cases. So they are more reliable. So on MRI, the early indicators of degenerations are T2 signal loss. T2 signal loss on normal aging, we see this signal loss is uniformly distributed over different levels, but the T2 signal loss in case of pathology we see only in one or two levels. In only one or two levels we see T2 signal loss. So this finding is often referred to as a black disc and has been applied to describe discogenic pain syndrome. So this is the cause for discogenic pain syndrome. It is described as such. And we will know now the typical starting of degenerative, the typical starting levels of degenerative process. Typically, degeneration starts in case of cervical spine from C5, C6 and C6, C7. But in case of lumbar spine, it is L5, S1 and L4, L5. Now, what is annular tears? Annular tears are the tears in the annulus fibrosus. It may be concentric type, maybe transverse type, transverse tears, also known as rim lesions, and also there are radial tears. So this is the image. Here we can see all the tears. In number 1, this is concentric type of tears. In concentric type of tears, the lamella of annulus fibrosus are torn apart. In case of transverse or rim tears, we are seeing this tear in the annulus fibrosus is just adjacent to the rim apophysis. So this is called rim lesions or transverse tear. And when the tear occurs from central part, that is from annulus to outwards, and rarely they touch the sensitive layer of the annulus fibrosus, the outer sensitive layer, then they are called transverse layers, the transverse tears. So the concentric tears are believed to be post-traumatic from torsion overload injuries, and transverse tears, it is believed that transverse tears influence and accelerate degeneration and are associated with discogenic pain. Transverse tears are also believed to be are post-traumatic in origin and are often associated with small osteophytes. Radial tears. Most of the radial tears do not reach pain-sensitive outer layers of the annulus, as we said. And radial tears are associated with disc degeneration, and a complete radial tear is necessary for progressive deterioration of the disc. So this is the tear that are definitely associated with the degeneration, and complete tear is needed for progressive deterioration of the disc. So what are the clinical core significance of annular tears? It is unclear what is the significance, but some annular tears without presence of any modification of the disc contours cause pain, and this is known as discogenic pain. And the annular tears often found in asymptomatic patients as part of the aging process. On MRI, the annular tears appears on T2 weighted images as a hypersignal intensity, and the annular tears occurs after repetitive microtoma. These repetitive microtoma cause annular tears to enlarge and become inflamed. And this phenomenon is seen by T2 weighted images, and this is known as high intensity zone. So, in the picture, it is the annular picture that is caused by repetitive microtoma, and repetitive microtoma causes annular tear to enlarge. So, this is high intensity zone. So, the high intensity zone is a combination of radial and concentric annular tears, as we shown in the picture. It is the combination of radial and concentric annular tears which merge in the periphery of the disc. The presence of a high intensity zone it is believed that the presence of a high intensity zone is related to discogenic pain. It has poor sensitivity. That means if the high intensity zone is positive, that does not mean that the discogenic pain will definitely occurs. And it has also limited positive predictive value. On T1, the extradural inflammation is seen as a zone of intermediate signal intensity. This is due to the replacement of the fat between disc and dural sac. The inflammation, due to the inflammation, we see on post contrast images high intensity signal or enhancement. So the lesions in the cervical spines, the rim lesions and prolapsed disc material are poorly recognized on MRI in case of cervical spine. Even in severely degenerative disc lesions of the cervical spine, we cannot see on MRI. In the dorsal spine, herniated disc fragments are often associated with abnormal straight or curvilinear densities on CT scan, also known as nuclear trail sign. On MRI, herniated disc fragment of dorsal spine may also be associated with a comet tail configuration in the axial plane. This sign indicates advanced disc disruption and degeneration and must be distinguished from an aging disc that has not filled. In disc herniation, the herniation is defined as the displacement of disc material. The disc material may be cartilage, may be nucleus, may be fragmented annular tissue, and may be apophyseal bone. So these materials, when they displaced beyond the limits of the intervertebral disc space, is known as disc herniation. And intervertebral disc defined, there is a boundary of intervertebral disc. The boundary is by the adjacent vertebral endplates and by the outer edges of the vertebral ring apophysis. But we have to exclude the osteophytes. So what does it mean by intervertebral herniation? This is the herniation through one or both vertebral endplates. It is also known as Schimmel's node and are often surrounded by reactive bone marrow changes. It is maybe due to a weak spot in the vertebral end plate, which is caused by a regression of the nutrient vascular canals, leaving a scar. What is limbus vertebra? It is formed when in case of young individual, a herniation of the nucleus pulposus through the ring apophysis occurs before bony fusion. A small fragment of the vertebral rim may become isolated. When in young individual, when herniation of the nucleus pulposus occurs through the ring apophysis before bony fusion, a small fragment of the vertebral rim may become isolated, and it will be called the limbus vertebra. And this limbus vertebra most commonly found in the lumbar region, less frequently on the mid cervical level. It is characterized by a defect in the anterior wall of the vertebra and usually at the anterior superior margin in the lumbar spine and at the anterior inferior margin at the cervical spine. So what is bulging of the disc? It is defined as a circumferential or generalized disc displacement involving more than 50% of the disc circumference. A bulging can be due to physiological cause seen on the L5S1 level and on mid-cervical level. Bulging may be due to advanced degenerative changes. Bulging may be due to a pseudo image caused by partial volume effect. Bulging can be associated with vulnerable remodeling, or bulging may be due to ligamentous laxity. Bulging may be asymmetrical, may be symmetrical, but asymmetrical bulging frequently seen in scoliosis. Two types of herniation, one is extruded disc and one other one is disc protrusion. We will call extruded disc when the base of the herniated disc is less than the diameter of displaced disc material, and it is seldom seen in asymptomatic patients, so it is frequently seen in symptomatic patient. Extruded disc frequently seen in symptomatic patient, but disc protrusion, it may be this protrusion may be focal or may be broad based. When less than 25% of the disc circumference is involved, then it is called focal disc protrusion. But when 25 to 50% of the disc circumference is involved, then it is called broad based disc protrusion. So let us talk about sequestrated fragment or free fragment. This sequestrated fragment or free fragment is also known as disc protrusion. This is the situation when there is no connection between the disc and the displaced disc material. Some cases imaging cannot show the continuity of the displaced disc material, and in that case we may use the word migration. Migration infers displacement of disc material away from the site of the extrusion. It's true, it means that the displacement of the disc material is away from the site of the extrusion, but it does not counter the continuity, or it does not concern the continuity. Regardless of the continuity, if the may be continuous or not continuous, but migration mainly implies the displacement of the disc material away from the site of the extrusion. What is content herniation? Displacement of disc material which is covered by the annulus fibrosus, and that is why it is called content herniation. Only discography can distinguish a content from an uncontained disc herniation. So we can classify anatomically. Disc herniation can be classified anatomically, and this is frequently used by surgeon. In the transverse or axial plane, we can classify the herniation into some subgroups. First one is the herniation may be central, that is posterior to the midline, may be paracentral, that is right or left central, may be right or left subarticular herniation. and it is the actually herniation of the herniation into the lateral races, or there may be herniation in the right or left foraminal region, that is the neural foraminal region herniation into the neural foramina may be occur. Maybe herniation may be due to in the extraforaminal space, that is outside the neural foramen. Herniation may be in the anterior zone. Anterior zone implies anterior and anterolateral zone. So this is about the transverse section, but in vertical plane we also classify anatomically from superior to inferior some into some subgroups. Those groups are pedicle level. The if herniation, either herniation may be at the pedicle level, herniation may be at the infrapedicle level, herniation may be at the disc level, herniation may be at the suprapedicle level. So spontaneous regression of the disc, herniation, it is commonly seen. Hernia is commonly regressed in lumbar spine, but in cervical spine it is described. In dorsal spine, spontaneous regression is rarely seen. There are some factors, if they present, they may predispose to spontaneous regression, such as free fragment herniation may predispose to spontaneous regression. Herniations with peripheral contrast enhancement on T1 weighted images, or if the T2 high signal intensity is more, then it will predispose for spontaneous regression. And also disc material exposed to the epidural space appears to resolve more quickly than subligamentous disc herniation, because epidural, these material that are exposed to epidural space gets more nutrition. Maybe they get more nutrition than the herniation that are located at the subligamentous disc herniation. Median or diffuse soft tissue herniation in the cervical space is more likely to regress than focal type herniations. So if degenerative disc disease, contrast enhancement when seen in posterior ligament, posterior longitudinal ligament, it indicates an inflammatory response. So, but when contrast enhancement seen in epidural space below or above the herniated disc, that indicates venous congestion. So, the last segment is about vertebral end plates and bone marrow changes. Modic described 3 degrees of degenerative changes in the end plate and in the subchondral bone. So Modic described 3 changes in the end plate, vertebral end plate, and in the subchondral bone. The changes are classified into type 1, type 2, and type 3. Type 1 is due to acute or subacute inflammation. Due to acute or subacute inflammation, bone marrow edema occurs, and as bone marrow edema occurs, T1 intensity is low, but T2 intensity is high. In type 2, indicate replacement of the normal bone by fat. So in T1 appears high signal, and in T2 appears ISO2 high, and this type 2 is most commonly seen. Type 2, it is type 3 is seldom seen and indicate reactive osteosclerosis. So on both T1 and T2 it is low. Here's the point: if only a part of the end plate is involved, this is most commonly the anterior part. So what is the correlation of modic changes? The transformation of type 1 to type 2 requires in most cases 1 to 2 years, and this transformation can be related to a change in patient's symptom, and this evolution is accelerated after osteosynthesis. That means if we correct the fracture fragment by nails or any other manner, then the evolution is accelerated. Modic type 1 changes are often observed in patients with painful lumbar instability. So, in painful lumbar instability is often associated with Modic type 1. Modic type 2 and 3 are chronic changes and they remain unchanged for years. So, thank you for listening.